Hello. So welcome back to this course in cluster randomized design, in cancer care delivery research. So in this session now, where we're looking at implementation and randomization, we're going to move on to look at randomization methods in cluster randomized designs. So I'm going to provide an overview of some of the pros and the cons of what we call different restricted methods of randomization. So we're going to start off by just summarizing over what we might call the simple or unrestricted randomization method. Also summarizing some commonly used methods known as stratified randomization and minimization, noting that these methods are used in individually randomized designs. And also go on to introduce the concepts of some randomization methods that are specific to the use of cluster designs. And these include covariate constraint randomization and pair matching. We'll go on to think about how we might implement these methods in practice, the importance of what is called a design-based analysis, and then finally provide some special considerations for multiple period designs. So how does cluster randomization differ to the sorts of randomizations that we might implement in a patient randomized design? Well, there's one key difference, and that is we are often randomizing a smaller number of units. So the average number of clusters in a parallel cluster trial is just 31, interquartile range 20 to 44. This is substantially fewer randomization units than we typically randomize in a patient randomized trial. In addition, the restriction methods that we might use also can either depend on cluster level characteristics or cluster level means, rather than the patient level characteristics. We'll clarify the meaning of these things in the next slides. And then there's another important difference, and that's how we implement the randomization. So the randomization is frequently implemented in what we might call batches, or alternatively, all clusters at the same time. Less frequently, the randomization can be sequential, insofar as it might mirror the patient randomized design, but that type of randomization is much less frequent. So let's start by looking at simple randomization. So in simple randomization, there's no stratification, no matching. It's what we might call an unrestricted method of randomization, with the exception that it's often implemented with allocation within blocks, such that there's a one-to-one allocation within each block. And this prevents an imbalance in the total number of units allocated to each arm. The advantages are that it's straightforward to implement, but the disadvantages are that with few clusters, it can result in imbalanced allocations, which might undermine the face validity, even if we implement the randomization within blocks. It's probably most suited to settings where we have a large number of clusters. Blocking will help ensure that there's a maximum balance in the number of clusters in each of the different arms, and random block sizes will prevent lack of allocation concealment. So this means predictability of the upcoming assignment. And in a few slides, we're going to talk more about the predictability and the importance of concealing that predictability. So other methods use what we might call a restricted method of randomization. So some examples of restricted methods of randomization includes those methods that are commonly used in patient randomized trials, such as stratification or minimization, but also these methods that are only used in cluster trials. And these are covariate constrained randomization and pair matching. Now, the advantages of using one of these restricted methods is that it should improve the balance of prognostic factors between the arms, and it should increase the power of the design. The disadvantages are that they are more complicated to implement. They require knowledge of these characteristics of the clusters before we randomize, but it can also induce what we call this predictability of the upcoming allocations. And again, we're going to talk about that later. So what sort of restriction factors might we use? Well, we can use cluster level covariates. These are variables that are assumed to be predictive of the outcome, so we might call these prognostic factors. And they also can be averaged across the clusters to provide cluster level means. So some common cluster level covariates are, for example, things like the type of cluster, the region, cluster size. That can be highly prognostic. Common cluster level means are things like the baseline measure of the outcome. Now these all have to be measured before randomization. They need to be well measured and they need to be reliable. And of course they also need to be prognostic of the outcome. In stratified randomization, this is a restricted method of randomization where we allocate within a strata defined by some categorical factors, and it can include blocking if we want. It's quite straightforward to implement, but the disadvantages are that it requires categorization of any continuous cluster level covariates. It can break down when there are only a few clusters in some of the strata. When we say break down, by that we mean that within a strata, even though we want it to be balanced within a strata, it tends to be not balanced within a strata. It needs a sufficient number of clusters relative to the number of strata, so it doesn't work well if there are only a small number of clusters and lots of strata, lots of groups, or lots of levels. Minimization is another restricted method of randomization. This calculates what we might call a global imbalance score and each possible upcoming allocation. And then clusters are allocated to the arm for which the imbalance is less. And we usually include a stochastic element to prevent total lack of allocation concealment. Specific advantages: it's useful when there's lots of covariates to balance on. Clusters can importantly be randomized sequentially as and when they are ready to participate. And it can also be implemented using existing validated approaches for patient randomized designs. There are some disadvantages. It requires categorization of continuous covariates, as does the stratification. And again, caution is needed in small samples as this might result in imbalanced allocation, as in stratified randomization. Covariate constraint randomization, another restricted method of randomization. It calculates all possible allocations in the randomization space, and for each of those, it computes a global imbalance score. And then it constrains the space from which the allocation is selected to those that have got the least imbalance. It, contrary to those methods that we have seen so far, can incorporate both categorical and continuous covariates, and it's useful where there are multiple covariates to balance on. Disadvantages are that it can be quite complex to implement, although there are specific tools. But more importantly, it's a non-sequential method. That means it has to be performed at one point in time or in a series of batches. And again, care is needed in small sample settings so that the space is not too restricted. Pair matching is again another method of restricted randomization. And then the allocation to treatment or control is made within a pair of just two clusters. We call these matched clusters. Advantages are, it's quite popular. It has lots of face validity appeal. The matching can be based on multiple characteristics, and it can also include an element of heuristic matching, just sort of like knowledge of the setting rather than specific measurements, which might not be that reliable. It can be used when there are few clusters, but it has to be used very cautiously with few clusters because it tends not to work well when there's only a few clusters, just like all the other methods that we have seen. It can lead to a reduction in the power if the matching is ineffective, so if the matching is a poor match. If one cluster drops out of the trial, that leads to the loss of an entire pair, which can have power implications. We can carry out what's called an unmatched analysis. So that means at the time of the analysis, we ignore that there was any matching in the design. That type of approach should only be used with caution. It might be reasonable if there are only a small number of clusters, but it can lead to inflated type 1 errors. So here's a nice example of a pair matched design. It was an evaluation of face masks to prevent COVID-19 spread. The cluster, the unit of randomization, was the village, and the design included 600 villages in Bangladesh. Randomization was using pair matches, so matching the villages into pairs and then allocating one did not receive face masks, the other two receive face masks. And the matching characteristics involved the region, COVID-19 prevalence, the population size, and the population density. Now, pair matching is likely to be effective only when something called the matching correlation coefficient is high, and that's around greater than 0.5. Now, this matching correlation coefficient is likely to be high only when the cluster size is large and the ICC is large. There's this nice quote that I think nicely sums up the recommendations around the use of pair matching in cluster trials. So matching is intuitively appealing, but we have confirmed in this study that unless it is possible to create very strong matches, it is less useful in practice than might be expected, especially for studies with a small number of clusters. So a big word of caution there. So what method might be best in a particular setting when we're thinking about best in terms of which of these methods will produce us the best balance across intervention and control clusters? So the question about stratification or matching. So if there are fewer than around 20 clusters, i.e. 10 pairs, then matching is unlikely to be useful. If you have more than 10 pairs of clusters, then matching should only be used if this matching correlation coefficient is greater than about 0.5, and remember this arises in settings with a large cluster size or a large ICC. When it comes to the choice of stratification or minimization, it can be useful to combine stratification with minimization. So for example, stratify on country, then minimize within country. Minimization is probably preferable when there are lots of covariates with lots of levels. Choice between minimization and covariate constraint randomization is mostly about implementation. And this is because minimization allows for sequential randomization, whereas covariate constraint randomization doesn't. Another word of warning here, so don't be tempted to include too many covariates into a restricted randomization procedure, because this can remove all possibility of any randomization element. And then the allocation becomes completely deterministic. And this relies on the covariates really being truly prognostic factors, and it removes all allocation concealment. So what's this allocation concealment that we've been talking about or mentioned a few times? Well, lack of allocation concealment means that there's a predictability of the upcoming next assignment. That means people in the trial can guess whether the next unit will be allocated to intervention or control. Now, the implications of this knowledge are that it leads to selective recruitment of clusters based on knowledge of what's coming up next. And it basically undermines the internal validity. It's an unconscious bias, but nonetheless, it turns out to be important. So very like the selection types of biases that we talked about when we thought about recruiting individuals within cluster randomized designs. So how we get around this and we mitigate these problems with lack of allocation concealment at the level of the cluster by including a random element into any restricted method that we use. We avoid stratification by site. And this is a recommended way of mitigating allocation concealment problems. But note that it's in direct contrast with recommendations that we've just presented to achieve best balance. So often there can be a trade-off between a randomization method in which you want to achieve best balance with one that you want to ensure there is lack of allocation, there is no problems with allocation concealment. One of the most important things to remember whenever a restricted method of randomization has been used, it's important to use what is called a design-based analysis. And this means that the analysis should allow for any covariates or variables that have been used in the randomization through covariate adjustment. Or if you've used a pair-matched design, using a pair-matched analysis, except perhaps in some settings where there are very few clusters. This is needed to ensure that the type 1 errors remain at 5%. Now, there is strong evidence that this design-based analysis is essential if we use minimization in individually randomized trials, if we use stratification in individually randomized trials, if we used covariate constrained randomization in parallel cluster trials, and it's likely to hold for all other types of restricted randomization methods in different types of designs, although the evidence there is weaker. How do we implement these methods? Well, we can use restricted methods used in patient randomized trials, so stratification and matching. And in those settings, any conventional validated implementation approach that is used in randomized trials, patient randomized trials, is absolutely fine. For those methods that are specifically for cluster trials, we do have to find specific implementation methodologies. And so for covariate constrained randomization, for example, R code and SAS code and Stata code as well exist to allow people to implement those methods. Now, one final word about multiple period designs. So the restricted methods of randomization that we have considered so far have mostly only been evaluated in parallel arm cluster trials, and there's been very minimal evaluation of these methods in stepped-wedge trials and cluster crossover designs. Now, there are some added complexities in these time imbalance designs. So there are limited evaluations of covariate constrained randomization in stepped-wedge trials. And those that have evaluated covariate constrained randomization in these settings have identified that it's not possible to obtain the nominal 5% type 1 error rates in a very restricted space. Rather, you should implement these methods not by sampling from the best 10%, but by excluding the worst 10%, for example. And then in addition, although we've said that covariate adjustment is essential after a restricted method of randomization, it turns out that in these multiple period or stepped wedge designs, it's desirable because it will provide you with power gains, but it doesn't seem to be essential to obtaining our nominal type 1 error rates. So that's a slight nuanced point for multiple period designs, specifically stepped wedge. So here's an example of a study that used covariate constrained randomization. It's a stepped wedge cluster randomized trial called the 3.0 study. It had 29 clusters, and these 29 clusters were allocated to 15 different sequences. It used covariate constrained randomization, and the covariates or characteristics that it balanced on were region, something called the mean CD4 count, proportion treated in the cluster for TB, and proportion with less than 4 years education. And then after creating a global imbalance score based on those 4 different characteristics, the allocations were restricted to those 1,000 allocations that were assessed to be the least imbalanced allocations. And then one was chosen at random from those 1,000 best allocations. Okay, so what methods of randomization are adopted in practice? Well, a contemporary sample of parallel cluster trials, published in 2017, reveal that a sizable number of cluster trials use a completely unrestricted method of randomization. So these are the ones here depicted in orange on the chart. Stratification is by far the most popular method of randomization. And pair matching and covariate constrained randomization are adopted, but relatively infrequently compared to stratification. And in a few study reports, it's actually unclear what method of randomization was used. So in summary then, there are different methods that we can use to implement a restricted randomization in cluster trials. Some of these methods that we use are the same as we use in individually randomized designs, but there are a couple of methods that are very specific to cluster designs. Any of these methods require measurement and knowledge of what we might call prognostic factors. These have to be measured prior to randomization. They should be prognostic of the outcome, and importantly, in cluster level trials, they have to be measured at the level of the cluster level. And if they're not cluster level characteristics, they have to be summarized in terms of cluster level means or something similar. If we have implemented a restricted method of randomization, then we must follow this with what's known as a design-based analysis. This means that we must allow for factors used in the randomization procedure in the analysis, and this is to maintain type 1 errors at 5%. There have been limited evaluations of these methods in multiple period designs, so perhaps when they are used in those settings, they should be used with caution. So here are some methods references that I've cited, and then a couple of study references that I've cited. And up next, in the next session, we're going to start to think about sample size determination, first of all in parallel cluster trials.